India and good morning for those who are in the US. Welcome to the international chapter of IOTA's 10th webinar. And yeah, I think 10 is a good milestone, a first milestone that we are reaching, I believe, with this project. We started off this initiative in October of 2020, and today's our 10th webinar. And as always, we have some fabulous speakers today, who has gracefully agreed to share their knowledge with us. Again, for those of you who do not know me, I'm Dr. Karthik Mani. I work as an assistant professor at the University of Texas Medical Branch in Galveston. I'm one of the board of directors of the international chapter of All India Occupational Therapist Association. I'm going to just kind of review a couple of housekeeping things and turn the control to our convener, Dr. Vijay Suple, who will introduce the speakers. So the first things, again, every time we are seeing this challenge of we get many more people registering for our event, but then eventually kind of like at the time of the webinar, we just see a portion of them. So please strongly encourage your friends to register and attend the webinar. And also if you're registering, please make sure that you kind of participate in the webinar and, benefit out of it. Because we are putting in a lot of effort and our time in this project to help the OT community in India as well as in other parts of the world. So please mute yourself. I already see some feedback. Please mute yourself. And if you have anything to say, raise your hand icon. We will invite you to talk. And after the presentation is begun, we would suggest you to, if you have any questions, don't interrupt the speaker. Keep your questions. Either you can put them in the chat box or you can keep them with you. And at the end of the webinar, that'll be an opportunity for question and answer. This webinar is being recorded. So, as a disclaimer, you can also see a message at the top of your screen. The recording will be made available on international chapters social media platforms like YouTube, and the link will be shared on other platforms as well. For those attendees who need a certificate, at the end of this webinar, I will post a link in the chat box after the presenters completed their talking. So you need to click the link. It will take you to a Google form. You have to complete the Google form and then go to your email and check your email. You will have received a certificate. And if there is any hiccups, please email international chapter iota@gmail.com. I'll also post that email in the chat box. All right. With that being said, I think I kind of covered the basics. And over to you, Dr. Vijay Suple.
So I just, Dr. Mani and Dr. Suple, I just had would you be able to take me off this because I think I'm getting all this admit people and it's covering my screen. Is there any way to take me off that?
Okay, I will see. I don't know how you are getting it.
I know.
I'm kind of like, if something pops up, I will right away admit them so that you don't really get them. But you shouldn't be getting it, but I don't know why you're getting it.
I know. Now there is one. Yeah, there is one right on my screen which says, you are getting it too, Jeff?
Right?
Yes. Yes.
Is it gone now or it's still there?
No, it's still there. It's admitting and the whole is covering the whole.
Let me see, is there a way that I can, viewing the lobby? Let me see. I will just go and check your name and then see.
Yeah, maybe.
Okay, let me see. Mute participant, make an attendee. Okay, I will make you an attendee. Is it better now?
Your role has been changed. Some actions like sharing content won't be available to you, it says.
So that's a challenge. Yeah, if I make you an attendee, then you will not be able to
share. Okay,
so let me go and change.
Yeah, go ahead and change it, and
let me go and change it back.
Best, yeah. We do the best we can.
Yeah. Ready? Okay, thanks, Karthik.
Give me 1 second, sir. I mean, I think you get started. Meanwhile, I will change the settings.
Yeah. Thanks, Karthik. Good morning, good afternoon, good evening, everybody, wherever you are. My name is Vijay Suple. I'm a convener of international chapter of AIOTA, and I'm based in Canada right now. Today's presentation topic of the presentation is occupational therapy assessments and interventions in neurovision deficits, an evidence-based approach. And the speakers are Dr. Sanchala Sen and Jennifer Worischeck. It's my pleasure to introduce Dr. Sanchala Sen to you guys. She has been an occupational therapist for 35 plus years. She completed bachelor's in OT from St. GS Medical College in Mumbai, master's in OT from TN Medical College, and doctorate in OT from Chatham University in USA. Dr. Sen worked in India for 14 years as a clinician in almost all practice areas of occupational therapy. She was founding member of School of Occupational Therapy in Nair Hospital and taught as a lecturer in TN Medical College, occupational therapy for 4 years. She moved to USA about 29 years ago and has worked in acute care, inpatient rehab, skilled nursing units, and assisted living facilities as a lead clinician and supervisor. She completed her board certification in physical rehabilitation from American Occupational Therapy Association in 2013. She has been teaching for 14 years in the master's program in OT at Winston-Salem State University in North Carolina. Dr. Sen's expertise lies in neurology and it applies to occupational therapy with an emphasis on the stroke. She has completed courses in neurodevelopmental techniques, that we call it NDT, and currently teaches those to OT students. She has presented at North Carolina State Conference and National OT Conference in USA on topics pertaining to rehab, stroke standards and care, importance of caregivers training in survival of the stroke and visual impairment in the stroke. Dr. Sen has held office positions at the State Association. She received the Clinical Field Work Educator Award and a Master's Clinical Award from North Carolina State Association in 1997 and 2005, respectively, for her contribution to the field of occupational therapy. We're very fortunate to have Dr. Sen as a speaker of this webinar today. And today's co-speaker is Jennifer Worischeck. Jennifer is a second-year master's student at the Winston-Salem State University. And she graduated with a degree in animal science from Morrisville State College in New York and a bachelor's degree in business administration and management from University of Central Florida. Her interests include pediatrics, mental health, and neurological rehabilitation. And currently she's working with Dr. Sen. So I welcome you both. And as I said, we're fortunate to have you here. And I'm confident that all the attendees will benefit from your knowledge. So Mr. Sen, you can take over from here.
Thank you, Dr. Suple and Dr. Mani, for that beautiful introduction. And Jen and I are very excited to be here and to share what we have learned. And hopefully you will get some knowledge from this, which you are able to take it back to your clinic or wherever you work. So like we said before, the title of our presentation today is Occupational Therapy Assessments and Interventions in Neurovision Deficits, and it's an evidence-based approach. Okay. So now it's not letting me advance the slide, Jen.
Can you see it on the next slide now?
Yeah, I do. But I can't see the presentation.
You can't see the presentation or the notes?
I can't see the note section like how it was before.
So maybe try to take control back again. Can you take control back and see if it'll let you advance it?
Let me try that because I don't know how the control went. Okay, maybe now, yeah. So the objectives for today are we are going to describe some neurovision deficits and their impact on function, identify some evidence-based assessments for use in neurovision deficits, and then demonstrate understanding of appropriate interventions for neurovision conditions. So we are hoping that participants will be able to take some of this knowledge back. Okay, I think if I click on the slide, it opens. So a little bit of background on this topic, what we have chosen today. So this was part of our research, which Jen and 4 other students were involved in for 2 semesters last year. And this involved 2 semesters again to collect and disseminate data, and was presented recently at our research symposium. For this part, they created education modules as part of the curriculum, and the participants were Lashara Barnes, Catherine Coates, Camille Crabtree, Brandon Wofolk, and of course, Jen Worischeck, under my guidance. And other students, unfortunately, could not be here because they are doing their level 2 fieldwork and they're gone in all different areas. So the evidence-based approaches we used included the brain injury visual assessment battery for adults, which is called the BIVABA. And then the education modules, once we completed, were, of course, reviewed by all of us, and then reviewed and approved by a low vision specialist who had certification in that, and an occupational therapist. Additionally, we also asked a peer faculty to review it. And as part of our research, which we are not going to include in today, but 6 OT practitioners from an inpatient rehabilitation facility completed educational modules and gave us reports, and that is what we presented at the symposium. So a little bit about the overview of the eye. So our vision is a primary way our brain engages and learns from the world. And we use vision to explore environment for resources and threats, and then use this information to make informed decisions to complete our daily activities safely. So let's look at some of the structure of the eyeball. And I know most of you know this, but this would be a nice quick review. So the eye consists of the iris, which is the colored part of the eye, which helps regulate the number of light entering it. And when there is bright light, the iris closes, and when there is less light, it opens. The pupil is the dark center, and you can see it on the picture there. And it in the middle of the eye, and this pupil changes size according to the amount of light that is available. So when you're in a bright light, it constricts and becomes larger for low light. The cornea is the next structure, which is the clear front window. And this transmits and focuses light into the eye. The retina, which is the, I don't know if you can see my cursor, but is the nerve layer lining the back of the eye. And this senses light and creates all those electrical impulses and then transmits them to the optic nerve and then to the brain. Continuing with the overview of the eye, there is the optic nerve next, which is a very important structure. Optic nerve is very thick. It is much thicker than all the cranial nerves. It's a bundle of more than 1 million nerve fibers, and this carries visual messages from the retina to the brain. The retina sees the images upside down, but the brain turns it, because of refraction, the brain turns it right side up. Then comes the fovea, which is the center of the macula, which provides the sharp vision. I'm sorry, I'm getting the admitting this, so I'm just pausing. Then is the lens. The lens focuses light rays into the retina. The lens is transparent usually, but later on it can become opaque, as in cataracts, and then that can be replaced. There is the choroid layer where you saw inside, and that's the blood vessel which provides nourishment to the eye. And then is the ciliary body, which contains muscles of the eye. Okay, how do I? Yeah, okay. I told Dr. Mani, I'm not used to Teams, so still getting used to it. So continuing with the overview of the eye, the cranial nerves. There are 6 cranial nerves that innervate motor, sensory, and autonomic structures in the eye. So those are the important ones for the eye. Those are the optic nerve, like I said before, the cranial nerve 2, oculomotor, which is 3, trochlear, which is 4, trigeminal, which is 5, abducens, which is 6, and then facial nerve, which is 7. And if you look at the structure on the right side, on your side, if you enlarge it, you will see where it originates. So continuing with the overview of the eye, out of all these nerves, out of all these cranial nerves, three cranial nerves are most important for us in the eye, and they control eye movements. That's the oculomotor, the trochlear, and the abducens. That's the 3, 4, and 6. So oculomotor controls 4 of the 6 movements, muscles in the eye, and the trochlear controls the movement of the superior oblique muscles, which moves the eye down and rotates, and then the abducens abducts the eye. So on the lower portion, you can see the 6 eye movements, which are supplied by all these muscles. So the medial rectus, and you can read it, which muscle does what. So continuing with this, vision is our most important sensory system, and it can convey large amounts of detailed information to us. So, needless to say, when you have visual impairments, it can cause, especially after stroke, which was our topic mostly, it can impact everyday functioning and, impact emotional well-being of a client. So completion of vision-dependent activities will be impacted, and the top 2 being reading and driving. And I want to emphasize a little bit, we living in the US, and Jen and I, we live in North Carolina, where we do not have much public transport. And so, people have to depend on driving. But then when they have these problems, they're very reluctant to give up driving because they will lose independence. And research has shown that even mild vision impairment can cause, from brain injury, can cause severe disruption in a person's life, whereas major visual impairments can be devastating for the client, especially the driving part of it. Other examples where functionally it can be impacted is, of course, you can see ADLs like applying makeup, picking and putting on clothes, matching clothes. IADLs are majorly impacted. Meal prep because of safety, and financial management and medication management. Again, I want to emphasize that in the US, many people, older adults, also live by themselves, and this is an important, so we have to take into consideration before they go home. Are they able to, financial management, at least maybe someone can help, but medication management, are they able to do that safely? So inadequate visual input can lead to many errors. And, when people commit these errors over and over, and then doctors tell them you cannot live alone. And so it lowers their self-efficacy and confidence, and they stop engagement in their valued occupations just out of fear and frustration. Additionally, visual impairments can inhibit the ability to process visual information quickly, because vision is the one sense which helps us make those adjustments quickly. When something, if you're walking, something coming, you move. If you have intact vision, you move quickly. So all those dynamic activities can become very difficult. And then this again can create limitations in community environments and lead to social isolation and depression, which is, as it is, big in stroke. So to continue with that, to give you a little bit more of a background for stroke prevalence and facts. So stroke is the second leading cause of death and disability worldwide. I know it is there everywhere. Over 30 million individuals experience a stroke each year, and the amount of people who have died or remained disabled has increased significantly since 1990. Stroke can cause motor, sensory, visual, and cognitive impairments, as we all know. But then 65% of stroke survivors have some kind of visual impairment. It may be ranging from mild, moderate to severe. And visual impairment post-stroke is linked to increased risk of depression. And this evidence in research, again, has a lot of significance for our area. And I don't know, some of you may be knowing, but we live in what is called the stroke belt. So the states of North Carolina, South Carolina, Georgia are referred to as being in the stroke belt area. And in fact, I think they said North Carolina was the buckle of the stroke belt. So we are right in the center of it. So incidence of stroke is very high due to a variety of reasons. So complications of stroke can cause havoc in this population and lead to poor quality of life and increased stress. So moving on, as we continue with the assessments and interventions for visual post-impairments after a stroke, which Jen will go over a lot, I want to talk a little bit about the visual perception testing hierarchy. People are still coming, yeah. So this is a model of Mary Warren. So Mary Warren is an occupational therapist. I'm sure people have heard about her. She's a pioneer of vision therapy in OT and is known as a vision guru. She conducts workshops to train OT practitioners on how to treat vision deficits after a brain injury. And according to Mary Warren, if you see on the left, the pyramid, visual processing can be conceptualized not as individual components, but rather an organized hierarchy that is laid out, stacked one on top of the other. And these components interact and depend on one another. If you look at the bottom of the pyramid, we have our foundational skills such as oculomotor control, visual fields, and visual acuity. If these are intact, then the person can scan well, recognize a pattern, then have a good visual memory, and then visual cognition, use that cognition to make informed decisions. So it is, again, we have to appreciate that it is not, though when we test vision, we test all those different ones, but the reason we test that is we see where the gap is, like where the patient has problems with, and then you start treating from there. So to successfully use vision in all these daily activities, all of these processes have to work in rhythm. So to make the process a little easy, we included a decision tree or a flow chart here to assist OT practitioners in deciding how to go about assessing and treating vision deficits, or where to start. Because when I was working in the stroke center or certified comprehensive stroke center, when we started this, and many a therapist who were not used to treating vision, they were like, I don't even know, where do I start? What do I do with it? And so this is like a little decision tree which helps you. It does not include everything, but it helps you consider some things. So when you're screening a client, you want to ask questions like, does the patient wear glasses? Are the glasses used for reading, driving, or both? Has the patient had any changes in vision since the stroke? So, check the cognitive status. Like we all know, cognition is the basis of everything before we do any kind of testing. Another thing which we face is, especially in acute care, does the patient have their glasses? Because many of them come like in the ambulance and forget to bring all their things. So that can be a big challenge. So the flow chart for screening, as you can see, there is acuity testing, which we test near and far vision, near read card, visual field, which can be done formal testing and which can be done functionally with all these tests, which Jen will go over a lot more. Then there is the active range of motion, where you can do tracking, test conversions and diversions. And then diplopia is one of the impairments we have added here, because diplopia is quite common in all our stroke patients. So how do you do, what are the tests we do? Cover, uncover, and then strabismus testing. I think, yeah, strabismus testing, and then tracking. So those are the things we kind of have in a decision tree. So step-by-step instructions for a client to do this. And with that, I'm going to pass over to Jen.
All right, so I'm going to be going over some of the assessments and interventions. We're going to start with the dominant eye test. And with many of these assessments and interventions, they are paired with a video. So you will see the items needed and the environments, as well as the instructions listed on the PowerPoint slides, as well as in the video itself. So the first one I'm going to be talking about today is the dominant eye test. And the purpose of this test is to determine the dominant eye of your client for further interventions. Items needed are listed and the environment is listed below. And this is going to be a video showing the process. If you can't hear it, please let me know. All right, so the dominant eye test is really important to do first, just so you have an idea of which eye the client prefers to use. And next, I'm going to be going over visual acuity. And visual acuity is very important because this is our ability of the eye to distinguish shapes and see details of many different objects at a given distance. So for near vision, that's going to be associated with many tasks like reading, writing, and fine motor skills. And then far vision, as we talked about earlier, has a lot to do with driving. So while you're driving, looking at stoplights or reading directional signs, and then also watching television. And then our vision, so for 20/20 vision, this is an indicator of the sharpness or clarity of our vision at a given distance. And then when we're looking at visual acuity, there's quite a few impacts functionally for our clients after a brain injury or a stroke. So your client might be complaining of blurry or fuzzy words while reading. They might be having some difficulty focusing when they're trying to read a newspaper or a book, or they could be also taking their materials closer to their face as they're trying to read. Maybe they're reading a book and they're bringing it really close because they don't have that acuity to see what's on the paper. And then again, these are going to be some videos showing how to test for far vision acuity. All of these tests, if your client typically wears glasses or contacts, they should be worn for these assessments. So again, the items needed and the environment are listed, and the instructions will be in the next video. All right, so this is the near vision acuity test. And for this video here, you're going to have them read the smallest line on the large print side and then read the smallest line on the other side. So one of the other alternate test options to look at the near vision acuity of your client would be this MN read pocket card. You can see the card on the right-hand side of this image here. It has examples of print, but it also has some nutritional labels and text messages and musical notes, which are also a good way to test for everyday functional activities. And then other ways to look at acuity testing would be for near vision and far vision. You can have your client identify faces at a distance or read a phone number for near vision. And then a few interventions for visual acuity would be to modify the environment and to do some different lighting or contrast with the background. And so for this one here, you could use different color cups. You could add lines of bright tape on the floor to increase the safety. So maybe putting a bright line at the edge of the bathtub or the sink. And then you could also use different lighting to make sure that the lighting is appropriate. And then as far as environmental, try to reduce clutter in the rooms. You know, cooking is extremely important. So maybe taking a look at the kitchen, can we modify this so it's less cluttered and more organized? Next, we're going to be talking about the visual field. And some of these slides here will be an overview, so I'll just kind of quickly go over them. So this image is showing the visual pathways. And just a couple important takeaways from this would be just knowing that if your left visual field is lost, this means that there's going to be a lesion in the right optic tract or the right cerebral hemisphere. And then deficits can include homonymous hemianopia, which we'll be going over later as well. Here's just some common visual deficits. Again, that's a similar image on the left, but over here on the right, this is showing what would happen to the eyes depending on where the lesion is. This is just providing a reference of the normal field of vision. We go over this in a later video, so I'm not going to read this, but it's here for reference. And then these images are also just providing some good visuals for the different testing arcs. This, as example, is the horizontal testing arc. And then this one here is providing just a good visual of the vertical testing arc. All right, so going into our next video, this is how you would test the visual field. So looking at the functional impact, if your client does have a deficit in this area, deficits can be unilateral, so central or peripheral, superior or inferior. Some of the main deficits, your client might complain of feeling off balance to one side. Maybe you're walking down the hallway and they don't want to take the lead, or perhaps they're using their fingers to trail along the wall to kind of guide themselves as they're moving along. A couple ways that you can test for this functionally. You can do scanning. There's the letter cancellation, the clock drawing, and last would be the line bisection. You can see the two images at the bottom here showing A, which is normal, and then the image B, which is the impaired. And we're going to take a look at a couple of the interventions. I will go over this more in depth later, but the interventions include scanning, using a couple different techniques, and compensatory strategies. And then for one of the other tests, we're going to take a look at the confrontation testing. So this is used to look at your peripheral vision and detecting any deficits in the visual fields, looking at the certain quadrants where your client has lost vision. A couple of the functional impacts of this, again, driving and complaints of blurry vision. And here is the video on how to do the confrontation test.